Hello everyone. Today we'll be discussing pineal parenchymal tumor of intermediate differentiation. Now this talk is continuation of our previous talk, that is pineocytoma. The outline of today's talk includes introduction, clinical features, imaging findings of PPTIDs and its differential diagnosis. Now these 2 points have been covered in detail in the previous talk of pineocytomas. Next is the macroscopic and the microscopic findings and the prognosis. So coming to introduction, pineal parenchymal tumor of intermediate differentiation is a tumor of the pineal gland that is intermediate in malignancy between pineocytoma and pineoblastomas and is composed of diffuse sheets or large lobules of monomorphic round cells that appear more differentiated than those observed in the pineoblastomas. Now, these may correspond to grade 2 or 3, but definite grading criteria remain to be defined. Now, what could be the masses in the pineal region? So, we have discussed this slide in detail in the previous talk. PPTIDs account approximately 45% of all the pineal parenchymal tumors. The median age group is 33 years. However, these may occur at any age group and there is a slight female preponderance. Now, the clinical features are similar to the other tumors occurring in the pineal parenchyma. Coming to imaging findings, on MRI, PPTIDs appear as large heterogeneous mass in the pineal region with variable cystic change, and these appear to engulf the pineal gland. They may commonly extend into the adjacent structures such as thalami, ventricles, and cause obstructive hydrocephalus. Calcification is common, which is best appreciated on CT. The T1 weighted images, the mass appears mixed to iso to hypointense, whereas on T2 weighted images, the mass appears isointense. Multiple hyperintense areas are seen on T2 weighted images within the mass, which reflect cystic changes. The post-contrast T1 weighted images show strong heterogeneous enhancement of the mass. We must remember that these tumors may invade the adjacent structures and also may spread along the CSF pathway. So imaging of entire craniospinal axis is therefore required to be done. Coming to differential diagnosis on imaging. So these are the DDs and pineocytomas, pineoblastoma, papillary tumor of the pineal region, pineal cyst, germinoma, pectoral glioma, and meningioma. We've discussed these in detail in the previous so the histopathology of this was the PPTID with neurocytoma-like appearance. Now you can see the tumor is moderately cellular and the nuclei are round to monomorphic with salt pepper chromatin appearance, and there are no rosettes and no necrosis found uh, in this image. So we proceeded ahead with the immunophenotyping, and this revealed strong synaptophysin positivity. Now, this is the second case of a 40-year-old man who presented with a recurrent pineal gland tumor. Uh, this was a consult case which I received from Dr. Datta Prasanna Katikar from Solapur. You can see the MRI reveals a lobulated solid signal intensity mass approximately measuring 36 into 33 mm in the pineal region, involving the tectum of the midbrain, adjacent splenium of the corpus callosum, the left calloso septal groove with moderate enhancement on post contrast. So this is the histopathology, and you can see the tumor shows extensive areas of calcification, and this is the lobular pattern of the tumor, the lobular architecture. Again, calcification here, and the tumor which is moderately cellular. So you can see the tumor cells here are monomorphic with dispersed chromatin, and there are no rosettes or there are no areas of necrosis. We proceeded with immunohistochemistry, and you can see the synaptophysin here shows a strong positivity. Neurofilament and NSE are also strongly expressed in PPTIDs. These are PPTIDs are new and negative, so these can be differentiated from the central neurocytomas, which are new and positive. Also, we need to have a check on imaging, because when the tumor is located in the pineal region or in the pineal gland, it is most likely to be a pineal parenchymal tumor. Now, the next DD we rule out is the oligodendroglioma, because you can see the cells have exhibited areas of calcification and round monomorphic cells. So, the PPTIDs will be OLIC2 negative, and there will be no IDH1 mutations, and 1p19q co-deletions will be absent here. The proliferation index in this case was 7 to 8%. And now coming to the MIB1 labeling index, the pineocytomas will show less than 1 proliferation index. In the PPTIDs, the range is between 13.5 to 16, whereas in the pineoblastomas, it may range from 25 to as high as 50%. So in both the above cases, we rendered a diagnosis of pineal parenchymal tumor of intermediate differentiation CNSWHO grade. Summarizing the histopathology, the tumor cells may exhibit two architectural patterns. First is the diffuse pattern, where the tumor appears neurocytoma-like or oligodendroglioma-like. And the second is the lobulated, with vessels delineating vague globules. Now, PPTID is potentially aggressive tumor, and it has moderate to high cellularity. The neoplastic cells are round, monomorphic with mild to moderate atypia, and the nuclei have salt pepper chromatin or dispersed chromatin, and may even show presence of small nucleolus. The cytoplasm in PPTIDs is more conspicuous than the pineoblastomas. The pineocytomatous rosettes are rare or absent, and there is no evidence of necrosis. Coming to diagnostic molecular pathology, small inframe insertions of KBTBD4 are recurrent and characteristic. The prognosis of these tumors is variable because they have variable biological and clinical behavior. Because we have seen they may be graded into 2 or grade 3. Now, these are locally invasive and they have potential for craniospinal dissemination. Some behave like low-grade tumors with infrequent and delayed local recurrence, while others are high grade with early local recurrence and craniospinal dissemination. The prognosis in PPTIDs is better as compared to the pineoblastomas. The median overall survival is 12 to 13 years, and the median progression free survival is approximately 7 to 8 years. Now the mitotic activity, Ki67 proliferation index, neurofilament protein expression have been used to subgroup low-grade and high-grade PPTIDs. However, this needs further confirmation. Take-home message, we should know classification of the pineal parenchymal tumors, and the PPTID falls intermediate between pineocytomas and the pineoblastomas. It may be grade 2 or grade 3. On MRI, the tumor may appear heterogeneous due to changes of cystic foci within. Coming to histopathology, the tumor is moderate to high in cellularity with monomorphic round nuclei which have salt, pepper like chromatin, and even presence of small nucleolus may be present. The cytoplasm is conspicuous as compared to pineoblastomas. Pineocytomatous rosettes are rare or absent, and necrosis is absent in PPTIDs. Now you should take into consideration the differential diagnosis, that is a central neurocytoma and the oligodendroglioma. And next is also consider whenever you have a tumor with well differentiated morphology like pineocytoma with the mixed areas of pineoblastoma. Now this is called as mixed pineocytoma, pineoblastoma. In such cases, the tumor should not be graded as PPTIDs while you look at the low grade areas. It should also always be considered as a high grade pineoblastoma. So these are synaptophysin positive tumors. Uh, we have seen how we grade them depending on the proliferation index. Coming to molecular genetics, KBTB4 alteration is a highly desirable diagnostic criteria. And coming to prognosis, the prognosis is better than pineoblastomas. So it depends whether it's a grade 2 or a grade 3 tumor. Thank you very much. I hope you liked the presentation of pineal parenchymal tumor of intermediate differentiation.